Hello and welcome to CardioVisual. I'm Matt Holden. Here we'll briefly discuss the cardiac conduction system and our EKG intervals. So let's kick things off with our cardiac conduction system. So here you can see it's made up of a bunch of different aspects. First off, we have our SA node or sinoatrial node. Next, we have our internodal pathways in our Bachmann's bundle. Internodal pathways connect the SA node to our AV node, and the Bachmann's bundle takes the impulses from our right atrium to our left atrium. Our AV node delays the impulse to allow for ventricular filling. The bundle of His carries the impulse from our AV node down into the ventricles. And the bundle branches and Purkinje fibers spread the impulse throughout our ventricles, which allow them to actually contract. Here we can see we have our left and our right bundle branch, and on the bottom we have our Purkinje fibers. So to recap, an impulse should originate in the SA node, which is located near the top right atrium, and will spread to the left atrium through our Bachmann's bundle. It will head to our AV node through our internodal pathways. From here it goes to the bundle of His and bifurcates to our left and our right bundle branches. Because the left side of the heart is so much larger than our right side, it needs more oomph, so it has fascicles. We have an anterior fascicle, posterior fascicle, and our septal fascicle, which connects our left to our right bundles. The impulse then heads down to our Purkinje fibers, which causes a coordinated contraction of our ventricles to send blood out to the body or to our lungs. So here's our normal EKG beat. We have our P wave, which shows atrial depolarization. In medicine, we like to overcomplicate things and use big fancy words. Atrial depolarization means atrial contraction. Our QRS complex shows ventricular depolarization or ventricular contraction. Our T wave shows ventricular repolarization, which is ventricular relaxation. You might notice why there isn't any atrial repolarization shown on the EKG beat. You can occasionally see it, but it's usually buried inside of the QRS complex. And finally, we have a U wave, which is thought to be delayed repolarization of our Purkinje fibers. When you have a very prominent U wave, it can suggest something like hypokalemia, which means low potassium in our blood. As we discussed, our P wave represents atrial contraction or depolarization. The duration of it should be less than 0.12 seconds or less than 120 milliseconds, and it should not be greater than 2.5 millimeters. Because our SA node is located inside of our right atrium, the first part of our P wave is going to be representing our right atrium. The left atrium is going to be the latter half. We can look at our P wave and see if there's any kind of atrial enlargement, but that's going to be a topic for another video. The PR interval is the time between atrial depolarization and ventricular depolarization. The duration is normally between 120 to 200 milliseconds. A short PR interval can indicate pre-excitation syndrome such as Wolff-Parkinson-White syndrome, and a prolonged PR interval can indicate a first-degree heart block, which is an excessive delay inside of our AV node. Now we talk about Q waves. So Q waves are the first negative deflection after our P wave. And it can be normal to have small Q waves in most of your leads, but not all of your leads. Pathological Q waves can occur during a heart attack, or also called myocardial infarction, and are said to be at least one big box wide or greater than 25% of the QRS size. The next type of Q wave to look for is our deep, narrow Q waves that kind of look like daggers, so I call them dagger Q waves. And this can indicate something called hypertrophic cardiomyopathy, or even hypertrophic obstructive cardiomyopathy, or HOCM. The QRS complex represents ventricular depolarization. This is when the ventricles contract to push blood out, like I said, to the rest of the body or to our lungs. Our left ventricle pushes out to the rest of the body, and our right ventricle pushes it into our lungs to be oxygenated. The duration of this needs to be less than 0.12 seconds or 120 milliseconds. A wide QRS can mean a bundle branch block or some tox or metabolic issue like hyperkalemia. The QT interval is very interesting. There's a lot of numbers associated with this. The biggest one I want you to know is that anything over 500 milliseconds is very concerning for something called torsades de poids or TDP, which is a ventricular arrhythmia. The ST segment should be isoelectric. Changes here are critical for diagnosing something called STEMIs, which are ST elevation myocardial infarctions or our heart attacks. This occurs due to a lack of oxygen getting to the myocardium or muscle of our heart. And normally I would talk about the T wave, but the T wave is very complex with the various morphologies that it can have. If you have a narrow peak T wave, you can have something called hyperkalemia. If it's more of a frowny, wide set based, or symmetrical T wave that can indicate some kind of ischemia, but this is a topic for a different type of video. So at the end, we learned that understanding our conduction system and our EKG intervals is crucial for diagnosing and managing our cardiac conditions. Make sure you subscribe, like, and check out our other EKG related videos.